And I invite the chairs, Dr. J.S. Bamra, CB, our chair of BAPIO, and Professor Derek Bell, OBE, President of Royal College of Physicians of Edinburgh. Both of them don't need any introduction, and they'll just take the session forward. Thank you.
Oh, well, go on then. Thank you very much, Derek, for giving me this pleasure. I'm delighted to say that this is it. This is the session. I mean, the first session was amazing. This is going to be, even in Ramesh's words, this is going to be even more amazing. New ways of thinking. Now, you remember that a few years ago we were talking about new ways of sinking, but now we've changed the theme. This is about positivity. What are the solutions we're going to bring within the NHS? That's all that the conference is about. And we're going to learn about how doctors can be supported in their jobs through actually harnessing teams, which is something we have been doing very well in the NHS, as you know. So I'm delighted that I'm co-chairing this with Derek Bell. Sorry, and I'm delighted not that I dropped the pointer. Hang on, folks. Thank you. We need an engineer to put this together. So, okay, well, I have the pleasure of... Was I going to invite the first speaker, Derek? I think you were going to invite the first speaker. No, I'll do that, okay. Well, this is a particular pleasure for me, because David Keane is the head of the task force, of which I'm a group of, which is actually looking at improving mental health nurse training in West Bengal. And I've been a recruit to that. There are only a small number of select people, and we've had a very successful first trip to West Bengal looking at the competencies of nurses, and Pradeep Sahai is here as the director of the Institute of Psychiatry. So this is a great pleasure really to invite David to tell us more about delimiting the role of nurses. Thank you, David. Could I invite all the panel members here, speakers here, sorry, speakers. We'll save time on that.
Oh, okay, thank you. Hello, everyone. Thank you for inviting me to present this morning. So yeah, as JS said, we've worked together on a project in West Bengal, which I'll come to actually, and Professor Saha here. I'll come to at the end and give you a brief overview, and I think we were talking earlier that next year we'll have a slot and we'll be able to tell you about the progress that we've made in that. But I've been asked to come here this morning and talk about delimiting the scope of nurses. So I'll give you a bit of background and I guess why I'm perhaps able to do this. So I'm a nurse by background. I've worked clinically for about 16 years, and a lot of that was in education and training of my nurse colleagues. And now I'm lucky enough to find myself with Jed Burns' team, working with Jonathan and Kath in the Health Education England Global Engagement team. So, first slide is very incomplete history. I thought this gives some perspective to nursing and how the roles evolved over time. So first of all, back in the mid-1800s, we've got Florence Nightingale going off to Germany, learning about attending a religious Protestant-based nursing school in Germany, then coming back to the UK, and we know in 1860 she set up the Florence Nightingale School of Nursing. Then we've got the world's first registration of nurses in New Zealand, then the first specialist nurses in America, and I think in the 1960s, and I think that's relevant because the most profit-driven healthcare system in the world was the first to recognise what nurses can bring to that health system, and in that is better patient satisfaction quite often, and also saving money. Then in the 80s, the specialist nursing roles moved over to the UK, and they branched out into lots of different names, and I'm sure as you've worked in the UK system, you've come across lots of senior nurses with lots of different responsibilities and kind of titles to their roles. Then in '98, we've got Barbara Stilwell, who was a community nurse, and she did some she released some research around advanced practitioners and what we would expect an advanced practitioner to demonstrate, the skills that we expect to see. And I'll come on to that in a second. Then in the 2000s, we've got regulation of advanced nurses in Australia, New Zealand, Israel, and across a lot of the OECD countries. In the early 2000s, well, in the UK, we've got legislation to enable non-doctors to prescribe. And in 2017, Health Education England released this Advanced Clinical Practice Framework. And I think relevant for the next few speakers as well is that I've just noticed a clock down there, slightly distracted, but it's all right. It's still got a fair amount of time. So the Advanced Clinical Practice Framework, so it's quite telling that this was developed by AHPs, so nurses, physiotherapists, occupational therapists, everybody feeding into this to develop a framework for advanced practice, and that understanding that advanced practice is relevant across the different kind of non-medical professions. And there's two parts to this. It's a great framework if you haven't seen it. So the first part is looking at what we would expect advanced practitioners to know and the level that we want them to practice at. And the second is looking at how an organisation might want to embed advanced practice within their clinicians. So kind of two-pronged approach, both for the clinicians and for people who want to develop the role within their organisation. So the kind of ethos of advanced practice, kind of started by Barbara Stilwell, really, I think, is these four pillars. So we've got advanced clinical knowledge and ability, management and leadership of teams and the profession as a whole, really, and the specialism that they're advanced in. Education, so that's both within the organisation they work at and encouraging the advanced practitioner to work with universities and to teach the wider professions. And that would be medics as well as other nurses as well as other AHPs. And research. So a fundamental part of this is being able to critically analyse the research that people are reading and to promote and disseminate that research to the wider organisation where they work and to the wider profession. So they're real flag bearers, really, for the specialism that they represent, leading across the whole system as well as locally within their teams, and as well, obviously, as well as providing the real advanced clinical care for patients. This slide I won't dwell on because it's slightly out of focus, but I think it's just really there it starts at the bottom with the care certificate, and which is kind of an entry level for people to come into nursing in particular, and then goes through degree level, master's level and PhD. And it's just really getting us to think about that you need a good career path. So if you're going to have advanced practitioners, you need to have a career path for people to feed into that role, so you're attracting the best people in, but also you need a career path above that role. So if you're attracting the best people into practice in an advanced way, then you need to allow them to really develop and evolve so you can get really the best minds in there. And then really onto the work that we did in West Bengal last year, which it kind of encapsulates. This has stopped counting down now. So just to so I've still got 9 minutes left, apparently.
No, you've got 2 minutes.
Oh, 2 minutes. So the work we did in West Bengal last year really encapsulates all of that AHP history. So the West Bengal government asked us to come and review the healthcare system. It's a small level project, not a massive piece of work, but to review the nursing in the healthcare system and give them some advice on how they might implement an advanced nurse practitioner role to support community care. And we came up with some recommendations, really. So first of all is about a unique role title and financial remuneration. So clinicians, we say it's not all about money, is it? But it does make a difference. You know, if you're given responsibility, you need to be paid for it. And also within nursing, it was very much noted that You need, if you're going to practice at an advanced level, you want your title to separate you from the rest of the nursing community, so people understand what you're doing and where you're practicing. Good career pathways, as I mentioned, around having somewhere for people to go after that role, as well as feeding good people into the advanced role. The wider nursing workforce, so really important that the wider workforce understand the role and what it contributes. So a lot of work to do there around making sure that people know what the responsibilities of that role are and how it will support them to do their job effectively. Recruitment and promotion processes, that's about getting the right people into the job. I think any advanced role, and that's true across any countries, it's an autonomous role. It's a role where you're thinking critically. You need the right people in that role, otherwise it can be dangerous and it can flounder. The period of transition, so there's a thing around supporting people to develop into that way of thinking and that way of working. It doesn't just happen. Some people have it naturally, other people need to be supported and developed. And then the new role, it can't be planned. You can't just plan an advanced practitioner role in isolation from the rest of the workforce. You've got to understand what the rest of the workforce are doing and how developments are going on. And then bigger picture and the future. So I think I'm just isolating a couple of points that would be great for you as doctors, and especially doctors with strong links to India, of what you can take away and think about from this is, for these kind of roles, we need support from the medics. That, you know, across all healthcare system, it's the doctors are in charge. The doctors say, if the doctors don't agree with something new or a change, then it tends not to happen. So we need you guys to kind of get out there and support it, really, and kind of broadcast back home how these roles don't really eat into responsibilities or eat into your role, but free you up to do kind of more complex patients and other things. Legislation and regulation. So if you go back to the first slide, very important steps throughout the evolution of nursing in particular is the legislation and the regulation. So, and some learning from West Bengal is if you're going to ask a nurse or a practitioner to practice at an advanced level, they need to have legislation and a legal framework there to protect them, as well as to support them to practice up to the level that you're asking them to. And then current programs, which we touched on at the beginning with JS, was around, now we're working with Saha and looking at, Professor Saha, sorry, and looking at developing mental health nurses. So hopefully we can come back and talk to you about that next year. Thanks very much.
Thank you.
What do you want me?
David, thanks very much for that. We now move on to the second speaker, which is Dr. Mahendra Patel, as Treasurer of Royal Pharmaceutical Society. He's going to particularly focus on the role of a pharmacist. So, welcome to your abbreviated talk, sir.
I think I'd better start because I know the clock is running very fast. Come on, young man. It's a pleasure to be here. Thank you very much for inviting me back here. And as a pharmacist, amongst a fellow colleague, as a nurse, and lots of physicians here, then it's an even more greater pleasure. How do we reduce the load on doctors? That was a title that I was given. I was given 15 minutes, but now I've been told it's 7 minutes, so if I'm going like a train, you know why. We all know about the 5-year forward view, and it's more about integrated care, looking after the patient, looking at prevention, looking at public health. How do we keep it sustainable? How do we look at transformation of services? And covering the 44 areas through the STPs and the vanguards. And I'm just trying to show you where pharmacists becomes involved in. Keywords that, because I'm just doing this off the top of my head now, really, that keywords: integration, working together, collaboration, knowing what each other healthcare professional does. I think that's important in a joined up delivery of healthcare service. And interestingly, I was at a launch of the British Heart Foundation House of Care programme in York earlier in the week, and it was quite surprising that they were talking about pharmacists and they were just talking about medication review. Really, we do more than just medication review, as you'll see in a minute. As you know, this is the problem that we have, the lack of investment, insufficient workforce, we're underfunded, and we have an inadequate infrastructure in terms of the IT as well, really. So it's all about care redesign, greater investment, developing the workforce, improving the work, reducing, supporting the workload that we have in a more efficient manner and getting the best out, and investing in the infrastructure in terms of development. Whoops. That's added to my 30 seconds. And then pharmacists' involvement. So where are we? We're already, in terms of the engagement in different organisations, we're working in part of the various Vanguard sites. We're also there in the local planning in some of the footprints that we have. The pharmacy's strength, we're talking about public health, prevention, etc. Isn't that where pharmacy involves, really? And that's where it resides now. That prevention agenda is something that we need to utilise more in terms of the pharmacy workforce. And then looking at the challenge, we know that one size doesn't fit all now, and it's tailoring that to the different groups of audience that we have, and engaging within the footprints, using the local pharmacy professionals and their networks. We've had a large investment, the Pharmacy Integration Fund, £42 million, and again, I'm zooming through this very quickly. Urgent care, and we're talking about how we can reduce the pressures on GP out of hours. We've got pharmacists in care homes, looking at polypharmacy, and how do we manage that? So it's not just about medicines, it's more about the wider management, about deprescribing, medicines optimization, the workforce development in terms of education, enhancing and supporting education. We're talking about advanced clinical framework as well, where pharmacists are also engaged within that framework as well, as David's rightly pointed out. But you didn't mention pharmacists. It's all right, it's fine. Digitally, making access more available, so we're having access to shared records as well. We've got summary care records. We're trying to move into a read and write form as well throughout every community pharmacy and in hospital as well, really, which is already there. Then we have pharmacists and GP surgeries. I was at a meeting a few weeks ago amongst a group of doctors, and they actually didn't know what the pharmacy and GP surgeries do, apart from just looking after the medication. This is managing long-term conditions, such as diabetes, cardiovascular disease. And it's supporting, that's supposed to take away some of the workload that doctors will have. So it's not just about, is your medication fine? It's supporting that patient wider and the holistic approach. This is where the advanced clinical practitioner would come in as well, and they go through training under that as well. Sorry, I'm really rocketing through. This is what we do, and we're talking, as I mentioned, and even within the elderly and the frail, pharmacists play a key role in prevention of falls. And this is something that we can then help in terms of reducing the burden on the NHS. It's those preventative measures that pharmacists can play a key role. If they're on antipsychotics, etc., they're feeling dizzy, then they're going to fall, etc. So it's how do we manage that patient properly and effectively. Obviously, we give an appropriate service in terms of medicines review. That's what we're experts on. And it's integrating. It's more about transfer of care as well, really. So when a patient is going from primary into secondary, secondary into primary, it's those records that causes errors sometimes in terms of the relay of information. And that's where pharmacists play a vital role, medicine reconciliation, etc. So it's about quality of care, patient safety. This is a GP forward view here in terms of getting pharmacists into the setting with a commitment of having a pharmacist for every 30,000 population, really. At the present moment, there is up to 2,000 whole-time equivalent of pharmacists in GP surgeries working, and that will extend. if you recall in the 90s when nurses were in a GP practice, we would think, well, we don't want to be seen by nurses. Yet today we can't imagine a general practice without a nurse being there. In 5 to 10 years' time, if not earlier, you will not be able to imagine a GP surgery without a pharmacist. I've been told I must go. These are some of the services that we do, improving urgent and emergency care. I'll just go through that in a minute, really, very quickly. When you're talking NHS 111, we have, for example, there's something in Yorkshire Ambulance Service in Yorkshire that are actually taking all calls back and preventing some of the readmissions through just a pharmacist controlling that NHS 111 and referral system. I'm going to have to skip all this. Care homes I've mentioned and how we can manage that. So if we have a pharmacist within each care home, public health record, we've got that. This is the bit that I was talking about, Yorkshire Ambulance Service, working as part of a multidisciplinary team, working together really. That's the key part. And saving other health colleagues time in more ways than one. This was where they have 9,500 cases, medicines inquiries were 5,500, 58% was just about medicines inquiries. Once the pharmacist got involved, out of that, most of them were dealt with through home management. So that stopped an admission into A&E really. I'm not going to go into this. Prescribing competency framework, nurses have started using it. This is to prevent errors. This is something that Royal Pharmaceutical Society provided and have developed, and it's been accredited by NICE as well. This is a standard that everybody should be using as prescribers. Minimise errors, minimise burden in any way, and put safety right at the top, really. Very quickly, hospital medication errors affected 260,000 diabetes patients in 2017. This was just out last week. This is where pharmacists can play a special part, really, because having a specialist pharmacist in each area can reduce that. We've got 2 diabetes consultant pharmacists up and down the country. If you look at the number of patients that we have as diabetic patients within a hospital ward, 40% of those are diabetic. That's a role for pharmacists to play in more ways than one. We have a whole program to upskill our pharmacists and our members, and an accredited program right through from start to the end of their journey. And these are some of our guidances. But I'm going to leave you with this. I can do things you cannot. You can do things I cannot. Together, we can do great things.
So it's my great pleasure to introduce Sajay, because not only because he is a fellow, very active member of the executive team of BAPIO, for which I'm always grateful, because you give very stimulating comments always. And so Sajay is going to tell us about new ways of working, how physician associates can improve the quality of care. And what I suggested is, what we agreed on was that Sajay would do the presentation, and then we'll invite Ravi together to sit with us as he's co-speaker with him. Thank you, Sajay.
Thank you, Jason.
You have 8 minutes. Start.
All right, I'll try. I have a declaration of interest to make. I'm a convert, basically. I used to vehemently oppose the new ways of working. They are not new anymore, because it is like 15 years old thinking. But I used to write in journals like BMA News, NSCJ News and everything against these advanced practitioners. And now, after 2010, I'm working in a department where there are plenty of anesthetic practitioners, and I regularly supervise some of them. So I would probably say I'm a convert. So the next few minutes, I'll just quickly give a background of the medical associate professions, which includes all these, and also some advantages and disadvantages, which, in my perception, EWTD has been blamed for all the workforce planning issue that happened in NHS for the last few years. And along with that, the visa changes and the IMG exodus obviously caused problem with the rota management, and budget cuts didn't help either. So basically, the demand versus capacity was the reason why all these new professional developments. This is the draft rota for my hospital. As you can see, the red ones are the theatres which are not covered at all. Green ones are the theatres which are covered by trainees alone. So more than 50% of the theatre lists are not covered. This is 2018, not 2002. So things haven't changed after so many years of starting these several projects to support these workforce gaps. It was in 2002 which originally the thought came out, and then you started seeing this kind of news in the media. And in 2006, the National Practitioner Program was started, which I think is archived after a couple of years of existence. And then in 2015, we had the NHS National Physician Associate Expansion Program, whereby they were trying to bring US trained PAs to work in the UK. And again, they only managed about 25 to 26 recruitment. Out of that, 6 were in general practice and the rest are in hospital medicine. And more recently, the previous health minister pledged recruitment of about 5,000 clinicians, including about 1,000 physician associates. So coming to individual practitioners, surgical care practitioners, it was started 2003. As you can see, the entry requirement is very stringent. Now there are more than 32 organizations who train and employ them. Physician assistant anesthesia, which I'm more familiar with, again started in Birmingham in 2005. Now more than 25 places they get trained, and the training pathway is like this. They get 27 months of focused training, including clinical and non-clinical training. The funding is fully by the trust. They are employed as a trainee, and the fee is paid by the trust, and graduate salary is paid while they are on training. And once they complete the training, they are employed in band 7 or 8A. These are the places where the PAs currently work. It's more than 50 hospitals across the country. And all the medical associate practitioners work based on the curriculum framework produced by the respective Royal Colleges and the Department of Health. Current status is that there are about 1,000 plus practitioners, including the students. This is from 2017. Compare that to the situation in America, where just physician assistants alone is 123,000 in 2017. And this doesn't include nurse practitioners or any other allied health professionals. And currently, all these universities offer physician association diploma. And coming to my local trust, we have got 8 advanced critical care practitioners working across 3 sites, and 5 physician assistants working in our theatres. They either run 2-to-1 theatre list or 1-to-1 trauma list during the weekend. And our new mothership, University Hospital Birmingham, have got a dedicated hand surgery unit completely manned by PAs. I mean, we all know the advantages. They fill the gaps left by the junior doctors, continuity of care, increased productivity, and possible reduction in the locum. But I'm going to focus, as always, I'm going to focus on the negatives, which is important because to have sustainability and acceptance among the rest of the profession, it is important that we focus on the negatives and try to do something about that. We always say about the cost efficiency. Are they really cost effective? The pay offered by the Physician Associate Expansion Program was 50,000 per year plus all the other benefits. And this is the salary banding of an advanced critical care practitioner. Like they start at 8A, which is now it is 42,000. This was a couple of years back. Compare that to the SAS specialty doctor pay scale, which is almost equivalent to that of a first-year associate specialist or a 4th or 5th year specialty doctor. So some people might argue that this is not that cost efficient. In theatre, if you need to make any profit or save money, I think we need at least have a 3-to-1 model, which I haven't seen happening anywhere across the country. And I don't know how many consultants will be happy to take on that responsibility of supervising 3 practitioners at the same time. other important thing is the scope of practice, indemnity and regulation. It is very variable. The scope of practice is very variable across the institutions. There are locally created structure for their scope, and obviously the NHS indemnity covers their action, but is that enough? The Royal Colleges recommend that they take additional indemnity. I don't think it is 100% covered at the moment. And at the moment they are unable to prescribe, which is going to be a hindrance in the flow of patient care and career progression. That is, I mean, this is kind of a career cul-de-sac for the associate PAs. There is nowhere to progress unless we invent some inventive solutions to sort that out. And registration is the most important thing. There is only a voluntary self-maintained register now, and GMC is actually actively involved in creating a common register in their umbrella. Coming to the safety and accountability, there have been several studies, mostly in US, because it's kind of a relatively new thing in the UK, and most of them says that it's kind of a mixed picture. The safety is there, but it is difficult to quantify the safety when they are completely supervised by a attending or a consultant all the time. Again, impact of training of junior doctors is another contentious issue. There have been several studies, and most of them are kind of a mixed picture, giving mixed pictures, saying that it can impact training in some specialties. For example, in surgery, this is a weekly rota for one of the surgical care practitioners. Most of the time, they are in theatre while the junior doctor is, admitting or clerking the patient in. So some people might say that it is an impact on training, but there are mixed views on that. And obviously, HE was planning to cut some funding to put that back on the physician associate training program, and that can cause problem. And this is a recent article from BMJ Careers, where a couple of people have come forward and said that everything has been very good so far, so we should get on with it. But I tend to agree with the view of the BMA JDC chair, and it's kind of a mixed experience so far. So, impact on other professions. Most of these associates come from other allied professions. So, are we taking away people from those professions to, make a PA post? And also, there are proposals to improve the doctor number by training the PAs and physios. So, what was the original point of training PAs at all? This is a true thing. This is an advertisement in America put out by the American Society of Anesthesiologists, because they felt so threatened by the presence of nurse anesthesiologists. Now the insurance companies prefer the nurse anesthetists because they are cheaper, they provide the same quality of care, so why should they go for the actually qualified anesthetists? So they had to actually go out and advertise about why they should be preferred over the nurse anesthetists. So it's important that we keep that in mind in the UK as well. So in conclusion, I completely agree that the medical associate profession is an addition to the existing workforce, but in my opinion, a locally driven need-based training will improve the sustainability and uptake. And obviously the emphasis should be given for regulation, prescription, scope of practice, and supervision levels. So I don't think I have convinced enough to say that I'm a convert, so I'll say I'm almost a convert. So thank you.
Okay, thank you very much. Now I have our final speaker for this session, which is Dr. Amit Koshar, who's going to talk about the role of a staff grades and associate specialist. Okay.
Yeah. So I'm Ravi Poddar. I'm the physician associate working for Western Hospital for last 6 years. So I'll just quickly, reflect being a physician associate. So I think Dr. Sanjan has already explored on the numbers of the physician associates, and I just want to say that PAs are like a pluripotent, so it needs to be used properly in NHS to boost the patient care. So before I mention my frustrations, I think I should acknowledge that I'm very proud to be physician associate, and I really enjoy being physician associate. But there are some frustrations about prescribing. I know that we can't prescribe, but can patient group directions used for PAs, at least to prescribe some antibiotics, IV fluids, and simple medications. This is something to think about. Use of senior PAs. I've been PA for last 6 years, but I think it's a bit frustrating that there is no career progression, as Dr. Sanjan mentioned, but can be used to work in the clinics with the collaboration with the medical team and other professionals. That's something to think about. ED triage, locally I'm talking about is the triage is done by the junior nursing staff, and that hampers the patient flow. So can the PA or the middle grade sit in the triage and filtrate the patient, start the diagnosis and the treatment early? This is something we need to think. Training and development. Unfortunately, there is no training and development pathways or protocols for the PAs, but with the, we should be thinking about the PA's retention and recruitment by developing this training protocol or some pathways to progress there in the future. And again, the training, specialty training, is it possible? Can PAs do a specialty training with the good support and the training? And I'm just thinking about myself in few years, maybe can I sit in MRCP exam, specially designed for PAs? Thank you.
That was well within 8 minutes. Thank you very much. Sorry about the confusion. So can we now invite Amit Koshar to come up to give the talk there? Thank you. Okay, thank you.
Morning. Thank you very much for the invite. Before I start, I'd like to make a couple of apologies. One is I changed the title a little bit. Instead of staff grade and associate specialist, I made it SAS because we have to bring specialty doctors into the picture. Don't particularly like the word utilized, but I left that there. And the second apology is when I was making the slide, I was told it would be more than 10 minutes, so I'll try and whiz through them. Do bear with me. Apologies. So I am Amit Kochar. I chair the BMA's SAS committee. So I am BMA, but I have a lot of Bapio in my blood as well. I am a physician of Indian origin. So, have you got the next slide? Shall we do this? Yeah. So when I started first, and I've been there 4.5 years now as a chair, my first job was to find out how many SAS doctors work in this country. And you'd be amazed, 20% of the medical workforce, almost 1/3 of secondary care in certain hospitals. And when I looked at the GMC figures, this is before the trainees started stepping out of training. On the specialist register, there were 70,000 odd. GPs, there were about 58, 59,000, but neither, and not in training, were 43,000 doctors. 43,000 doctors. That is a huge amount. 50% of them are female. 64% of them are BME. In certain hospitals, 82% doctors are of Indian origin who are in the SAS grade. Currently, we have only one grade open, and that's the specialty doctor grade. 2 weeks ago, after severe negotiations with the Secretary of State for Health, I have managed to get a written assurance that the associate specialist grade will reopen. Thank you. Yeah. And we are in discussion as to how to make that happen. So what do we do? What do SAS doctors do? Staff grade, associate specialists, and specialty doctors? Well, we do a lot of things. A colleague of mine in Doncaster did a survey about patients attending A&E, and he found 6 out of 10 patients that came to A&E in that month saw a SAS doctor first. That's the kind of workload we undertake. David Nicholson, who was the last chief exec of the NHS, said we were the backbone of the NHS, and that is going to improve as we